So in next 20-25 minutes we shall be talking about the statin, when to start and stop. Lot of things remains in the air about the statin, whether it is to be used or not, whether the cholesterol is really harmful or not. Many a times it remains the half truth and many people don't tell about the full story. So let's have why do we need to start a statin, and early start would be beneficial for the optimal benefit. We all know that 75% lipid is synthesized in our body. 25% lipid is only coming from the outside sources, what we call it the dietary sources. But most of the time we understand that diet is the only source of the cholesterol or lipid or everything what we are getting to have fat in our body. An example is that about 1990, if I am not wrong, there has been a drive that we should stop eating the saturated fat. At that time, a very popular saturated fat, dalda, was in the market, and it has been suddenly stopped. Some people said that it is having the animal fat, and because of what? It was stopped and people started using oil. And that was the drive of multinational companies to consume their palm oil, and the palm oil which was being imported from the America, USA, and that has to be accommodated in the Indian market. For that purpose, this drive came up, and our own resources, vegetable oil, which was hydrogenated vegetable oil, that has gone out of the market. And it was said that once now you have stopped eating the ghee, now you have stopped eating the saturated fat, then probably the incidence of cardiovascular adverse outcome shall be lesser. But you remember at that time there was only one cath lab and only one cardiac catheterization center across the country in AIMS, and one was the private in the Delhi, that was the Escort Center. But now it is in every city. Every small city is having cath lab, every small city is having the cardiac catheterization center, and all are going on very well. So what is the outcome of this story? It really did not go low or slow. Incidences has gone up, and in fact they have gone up to a certain extent that now they are increasing like anything. Some onus you can give to the diabetes and metabolic disorder, and of course the metabolic disorder is also one of the important culprit for the hypercholesterolemia and dyslipidemia. But the more important thing what is to understand, it is to be stopped. What was happening in the earlier days, our forefathers were doing lot of physical activity. When they used to eat the deshi ghee, they used to eat the saturated fat, but they were consuming it regularly, and that's why probably statin was not required in those days. And in those days we do not have any such study in which we can say that how many people were getting early death and early mortality because of the cardiovascular reason, because most of the time they are not really monitored and they are not really known that what was the cause of the death at that time. Now we know every death is having some cause, and we try to find out what could be the cause of the death whenever it is happening. So largely we know that lipid is having not only the cholesterol, it is having 5 segments of that. What are those 5 segments? Total cholesterol, chylomicron, VLDL, very low density lipoprotein, LDL, low density lipoprotein, and high density lipoprotein. So all 5 types of the cholesterol is not harmful. The only harmful cholesterol or maximum harm caused by the LDL, and LDL is also that LDL which is a small dense LDL, that is more harmful. Other LDLs are also harmful, but LDL, small dense LDL, is having the tendency to get deposited in the atherosclerosis. On the other hand, HDL cholesterol, high density lipoprotein, is that protects us from the cardiovascular disease. So whenever these 2 things are the balance, then probably you may not get the cardiovascular adverse outcome even if your cholesterol is high. For example, your cholesterol is 200 and your HDL is 100, then obviously you are safe. But your HDL is 40 or 35, and rest everything is the non-HDL, then you are at the risk. This thing is not told by the videos and by the people, those who are giving you gyan in the social media. So that is the explanation what we get the information, or we can half cooked information or half truth on the social media most of the time. And in the social media many a times we also do not know the person who is telling us what is the qualification of him. Many a times some least qualified people, those who may not be having any background or any information about the science and medical science, they may be giving their informations as a expert. So that is the biggest issue regarding that. Now come over to that, why hypercholesterolemia, dyslipidemia is increased so much in our society. Nowadays, what is happening, as I already said, our forefathers, our ancestors were doing a lot of physical activity. Now we don't do any physical activity. In last 30-40 years, this sudden change came into our society. Then we stopped doing all the physical activity. We started eating every kind of the stuff with the high calorie. At the same time, earlier we were the people those who were having the life, or earlier we were the creature who was having the life from sunrise to sunset. Now we are 24/7. Now we don't have any kind of the holiday, neither regarding the food nor regarding the work. Keep on working late night, and whenever we are awakening late night, we are eating also. We are continuously consuming something, and that is also increasing the incidence of uncontrolled diabetes, pre-diabetes, all diseases which are related or getting arisen of the insulin resistance. Here I would like to try to explain you. The insulin resistance is the mother of all evils. Insulin resistance remains in our body, especially in the Indian race. It is inherent since from the genetic level, and because of this inherent insulin resistance, if we continue doing the physical activity, we keep on checking this. But once we don't do enough physical activity, this starts getting up since from the early days of the life. Nowadays it is happening, even our kids are also not having enough physical activity. All the playgrounds have been abolished in the school. All the schools are not promoting all the games, all the sports are on the mobile phone only. People are playing cricket but on the mobile phone. People are playing football on the mobile phone. People are playing every game, but not by using their foot and hand, only by using their fingers. So their fingers are the playing, and they are the most working organ of our body. And that is the reason when you do the glucose level from the finger, it comes many of the times not matching with the venous glucose level which is taken from the venous blood. Why? Because this is the rule of the body. Wherever the requirement is the most, the redistribution of the glucose and energy in that area. So once you are using your fingers, most all glucose comes to your fingers only. That's why it is not matching to the many times the glucose which is in the venous blood. So here you can say that environmental factor, when they are associated with the genetic factor, they are responsible for the increased insulin resistance, which is evident in the form of the increased free fatty acids. Increased level of the insulin resistance gives rise to the increased free fatty acids in addition to the hyperglycemia, and this free fatty acids enters into the liver. So actually this free fatty acid is constituting 59% of the total fat which is entering into the liver. 59%. Diet related fat is responsible only 14% which is entering into the liver, and remaining 26% is coming from what? You would be surprised to know that remaining 26% is coming from carbohydrate, aloo, chawal, what you are eating, and you are drinking the high energy drinks, Coke, Pepsi. This is coming from that. Now you will be surprised that I am eating carbohydrate, how can it be changed into the fat in our body? This is called as de novo lipogenesis. de novo lipogenesis takes place at the level of the liver. And once your energy what you are taking inside of you and remains unutilized, then it goes to the storage organ. The first storage organ is the liver. First the glycogen storage are full, then muscle glycogen storage are full. Once all these storage are full, still energy is left because now we are eating 24 hours. जब हम 24 घंटे खाते हैं और खर्च कुछ नहीं कर रहे, एक्सरसाइज कुछ नहीं कर रहे, तो कहीं तो जाएगा ना जो कुछ खा रहे हैं. So that goes into the liver, gets converted into the de novo lipogenesis. That's why you get the free fatty liver disease even in early days of the life. Even 15 years, 20 years youngsters are getting the fatty liver disease if you go ultrasonography of them or you go for the fibrous scan. So this is the reason, that's why I showed this picture to you. Now come over to the studies, what we call the evidence. We physicians don't talk anything without having the hardcore evidences. We don't talk anything just simply on the basis of the reasoning and logic. Until unless the logic and reason is confirmed by the evidence, we don't promote it. Now the Inter-Heart study says, out of the all risk factors which can give rise to the heart disease, including diabetes, including smoking, alcohol, hypertension, abdominal obesity, lipids are on the highest level, which is giving rise to cardiovascular adverse outcome out of the all 9 risk factors. Exercise is also risk factor. Exercise means poor exercise, less exercise, means lack of the exercise.
Okay.
Now this is the estimation. How does we get the LDL cholesterol level which is associated with the risk of the cardiovascular disease events. As far as the secondary prevention is concerned, this red line is showing the secondary prevention. As far as the secondary prevention is concerned, you can get clear idea as the cholesterol is increasing, the cardiovascular events are also increasing. It has been proven by multiple trials and studies like Proposer, CARE trial, lipid trial, HPS trial, and multiple trials are there. On the other hand, primary prevention, for which we are more emphasizing nowadays to the people, it is also showing the relation between the cholesterol, LDL cholesterol amount with the event rate. Although it is not that steeper as is in the secondary prevention, but definitely it is showing which is statistically significant. As the amount of the LDL cholesterol is increasing, you can see the event rate is increasing. It has been proven by all head trial, FCAPS trial, TEXCAPS trial, VOSCOPS trial, and multiple studies has given this. Now come over to the guidelines and what are the recommendations of the European Society of Cardiology. European Society of Cardiology says, if it is for the secondary prevention, I think everybody would be agreeing for the secondary prevention. There is not much scope to disagree for the secondary prevention of the cardiovascular disease using the statin or cholesterol lowering agent. The only dilemma comes for the primary prevention. Do we really need to give it for the primary prevention? Should we give it to the people, those who are less than 40 years of the age, those who are less than 20 years of the age? I shall be coming on that. But as of now, the recommendation is that if you are using the statin or any cholesterol lowering treatment for the secondary prevention, for the primary prevention in very high risk patients with or without familial hypercholesterolemia, your target for the cholesterol lowering should be the 50% reduction of the baseline. If your patient is having the LDL cholesterol, I am talking about the LDL cholesterol, not total cholesterol. Total cholesterol is of no use if your patient is coming with the total cholesterol. The only benefit is when you are getting the report of the LDL cholesterol or as well as HDL cholesterol. So if your patient is having the LDL cholesterol 120 and having the familial hypercholesterolemia, having the very high risk for the atherosclerotic cardiovascular disease, or you are needing it for the secondary prevention, it should be reduced 50% at least, means 60, less than 60 it should come down. Or if you are looking for the target which is in the numerical value, it is a 55 milligram per deciliter or less than that should be maintained. But on the first end, you try to come to the 50% and next step should be to bring it less than 55 milligram per deciliter. For patients those who are already having the atherosclerotic cardiovascular disease and already had an experience of MI or any cardiovascular event within 2 years, not necessarily of the same type, they should be given the statin based therapy or any cholesterol lowering therapy in maximum tolerating dose to reduce the cholesterol level less than 40 milligram per deciliter. In patient at the high risk and LDL cholesterol reduction of more than 50% from the baseline and LDL cholesterol less than 70 are recommended. Means I was talking about a very high risk, now I am talking about the high risk. And now the moderate risk, you are permissible up to keeping the LDL cholesterol up to 100, and individual those who are having the low risk means there is no risk factor, no genetic inclination, then you can go even up to 116 milligram per deciliter, it may not be of harmful. So if a person says कि मेरा कोलेस्ट्रॉल 300 के ऊपर है पर देखो मैं तो बिल्कुल ठीक हूँ, it depends on the genetic makeup of individual to individual. It should not be a rule for everyone. Data for the primary prevention. American Heart Association guidelines says for the primary prevention, assess the atherosclerotic cardiovascular disease risk in each age group. How will you assess the atherosclerotic cardiovascular disease risk? ये भी एक सवाल आएगा कि हम कैसे कैलकुलेट करें. There are a lot of scores which are available on the internet. Few of the scores are in my mobile also. I can send it to you after this lecture. So those are the score, Q risk score, Framingham Heart score, and multiple scores are there which can help you in knowing about your atherosclerotic cardiovascular disease risk in next 10 years. So when this risk is there, everyone should be adhered to the lifestyle modification even since from the beginning of the life, means childhood is the right time to implement for the healthy lifestyle, to implement for the lifestyle modification. So it is not the lifestyle modification which should be instituted once you are getting the disease or once you are getting adult or once you are getting weight gain or you are knowing that your cholesterol has started increasing or you know that your diabetes is coming up. So it is needed since from the very early childhood. Even 0 to 19 years age group patients may need statin if they are having the familial hypercholesterolemia. Familial hypercholesterolemia is a genetic condition which remains in some of the families, runs in those families. So those children who are coming up from those families, they can be a candidate for the statin. After 20 to 39 years, of course, the healthy lifestyle or lifestyle modification is required for everyone, but at the same time, you can consider a statin if the family history for premature atherosclerotic cardiovascular disease and LDL cholesterol is there more than 160. Between 40 to 75 years, if it is between 70 to 190, of course, the statin could be a candidate and depends on the 10-year atherosclerotic cardiovascular disease risk, what you will be calculating. If it is less than 5%, only lifestyle modification will work. If it is between 5 to 7.5, then you should go for the moderate intensity statin therapy. If it is between 7.5 to 20%, then you go for the moderate intensity statin therapy with reduction in the risk enhancer, doing the lifestyle modification the same time. And if it is more than 20%, then of course you need to do the aggressive reduction in cholesterol, whether it is with the statin. If it is statin is also not working enough, then you can add the other agents also. If the risk decision is uncertain, consider measuring the CAC, that is the arterial calcification. LDL cholesterol more than 190, you don't need to do any risk assessment. Start the statin if LDL cholesterol is 190 or more than that. If your patient is having the diabetes and ranging between the age of 40 to 75 years, no risk assessment is required, start the statin. What is the recommendation is there? Diabetes mellitus in age 40 to 75, risk assessment is considered only to know whether to high intensity statin देना है या low intensity, moderate intensity statin देना है या low intensity statin देना है. So statins are considered as first-line agent for primary prevention of the CVD. Now, what is the high intensity statin therapy? What is the moderate intensity statin therapy? What is the low intensity statin therapy? Atorvastatin 80 milligram, rosuvastatin 20 milligram to 40 milligram is considered as a high intensity statin therapy. If you want to go for the moderate intensity statin therapy, of course, 10 to 20 milligram of the atorvastatin, 5 to 10 milligram of the rosuvastatin, 20 to 40 milligram of the simvastatin, 40 to 80 milligram of the pravastatin, lovastatin, which are not being used in our country. But pitavastatin is being used in our country, 2 to 4 milligram, is in which very good statin for the diabetes patient, but it is low profile and not very strong statin, I can say that. Low intensity statin therapy includes the same 10 milligram, simvastatin, pravastatin 10 to 20, lovastatin 20 and pitavastatin 1 milligram or less than that. So each 1 millimole reduction of the LDL gives more CV event reduction according to number of years in the trial and comorbid conditions as well. So if you are in the 1 year in the trial, you can have the 11% reduction in the risk. If you are 2 years in the trial, 24% reduction in the risk. 3 to 5 years in the trial, then 33% reduction in the risk, and more than 6, of course, the 36% reduction in the risk. There has been a study or meta-analysis what is called as when it's been published as a Voyager. In this meta-analysis, rosuvastatin has been compared with the atorvastatin for lipid lowering, and it has been found that rosuvastatin is stronger enough to reduce the LDL cholesterol. Rosuvastatin 40 milligram more effective than any other statin for the LDL cholesterol and non-HDL cholesterol lowering. But CAR study, which has been done in the patient those who were having diabetes, could show the 37% risk reduction in CV events with atorvastatin. So atorvastatin have been found to be quite promising in patients with diabetes. Even 10 milligram of the atorvastatin could reduce 37% risk reduction. 50% risk reduction in ischemic stroke in diabetes patient could be achieved with the atorvastatin. Atorvastatin, if we talk about the primary prevention in high risk patient, ASCOT LLA trial says that for reduction in the non-fatal MI and fatal coronary heart disease, 36% reduction could be achieved in 3.3 years in 10,305 number of the patient. Secondary endpoint was considered as fatal and non-fatal stroke, where we could see that 27% risk reduction. There is another study which has been done in the rosuvastatin. That was a Jupiter study, very popular study. In this trial, we did the study of the rosuvastatin in patients, those who were having the low LDL and high hsCRP. hsCRP, high inflammatory markers were there. Patient on rosuvastatin achieved LDL cholesterol level of 55 milligram per deciliter, what is the guideline of all the organization, 50% reduction over the baseline at the end of the study. They were not having any prior cardiovascular disease or diabetes. Men has been included, those who were of the 50 years or more than that, and women has been included 60 years or more than that. LDL was less than 130 in all these patients, but hsCRP was more than 2 milligram. So in this Jupiter study primary trial, what we could see that risk reduction after adding the rosuvastatin was 44%. In patient without diabetes and CVD with high risk, with high level of the inflammatory markers, rosuvastatin significantly reduces the CV events by 44%. There is another thing what we could be noticed in the Jupiter trial. Rosuvastatin also given rise to the new onset diabetes by 28%. So this is the another challenge which has been faced by doctors and medical fraternity. On one side, we are giving the statin to reduce the atherosclerosis, to reduce the cardiovascular events, but at the same time, the same statin is giving rise to the new onset diabetes in 28% individuals. And that is a good sizable number. A lot of long debate occurred for this, and ultimately it has been found the benefits of adding the cholesterol lowering agent and reducing the cholesterol is very much needed if the patient gets diabetes only those patients will get the diabetes who are having genetically inclined. If you are adding up the cholesterol lowering agent, then probably you can save them for the associated cardiovascular disease, because diabetes is also causing the same adverse end outcome. What has been seen in the HOPE-3 trial, 25% reduction in primary endpoint in 12,705 number of the patient with 10 milligram a day. Atorvastatin has been having the stronger evidence for primary prevention, more than 5,000 patients in diabetes. So diabetes patients are excluded or underrepresented in rosuvastatin trials, especially the Jupiter trials. So overall performance was very good of the rosuvastatin, but atorvastatin was having the stronger evidence or better evidence in patients with diabetes. Now come over to the secondary prevention. In secondary prevention, if a person is having the clinical atherosclerotic cardiovascular disease, of course the healthy lifestyle is very much needed. If he is carrying the very high risk atherosclerotic cardiovascular disease, then high intensity or maximum therapy of the statin is needed. If despite that your patient is not being able to bring down its LDL cholesterol less than 70, then you are advised to add the ezetimibe. If your patient is still not able to bring it less than 70, then PCSK9 is the ideal choice considered to be added. Here we can say that randomized control trials supported efficacy was more commonly seen with the maximal statin therapy as compared to the others. If on clinically judged maximal LDL cholesterol lowering therapy and LDL cholesterol more than 70 or non-HDL cholesterol is more than 100, then add PCSK9, it is more reasonable choice. On the other hand, very high risk atherosclerosis is not there, then if your patient is more than 75, you judge whether it is needing the therapy or not if you are going to initiate, but if it is being taken by the patient, it should be continued. Age less than 75 years, then goal should be reduction of the LDL cholesterol less than 50%, or if high intensity statin is not tolerated, of course a moderate intensity statin can be tried, but something must be offered, and we should try always to bring down the LDL cholesterol level less than 50% of the baseline. If on maximal statin therapy LDL cholesterol is still continuing with the more than 70, then addition of diazetimib is the right choice. New European Society Cardiology guidelines recommend LDL cholesterol goal less than 40 for recurrent ACS event. This I am talking about a secondary prevention. I don't think secondary prevention anybody would be having any dilemma or disagreement to start with the statin. A number of trials has been done with the various doses of the statins, the various varieties of the statin, and all have been found to be effective. But the most effective have been found the atorvastatin. What we could see that atorvastatin 10 milligram for 3.3 years only, you can see that 35% reduction in the LDL cholesterol with 13% relative risk reduction and 36% mortality reduction. What we could not see in other lipid lowering agent in such a short interval. Statin therapy and outcome after elective PCI, what we could see that after elective PCI also it was thought that statin is performing well and it is needed. Of course you have done the PCI, many people think that अब तो हमने निकलवा दिया अपना clot, अब तो हमने सारी जड़ हटा दी, तो now our arteries has been as good as it was earlier. This is not true, because always there are the chance of the re-blockage, always there are the chances of the PCI may need again if you are not doing the statin therapy properly. So primary endpoint would be the post-PCI incidence of the MI has been found to be reduced significantly. Only 5% events we could see of the rising CKMB in recipient of the statins. Possible mechanism of the clinical benefits have been considered, that multiple studies has worked on the various mechanism, and it has been found that all the mechanisms are working well with the atorvastatin, either it is through E-selectin or VCAM1 or ICAM1. High dose versus low dose pitavastatin in Japanese patient with stable coronary artery disease have been found to be reducing the primary endpoint by 19%. Pitavastatin is not very stronger cholesterol lowering agent, but it has been found that 1 milligram pitavastatin has also been working enough. So statin is important. It is to be given. Whatever you can tolerate and your patient can tolerate, you can offer to him. European Society of Cardiology guidelines says that lipid lowering treatment beyond the statins is needed if the statins is not working. What could be that? It could be the ezetimibe. If you are not getting enough results from the statin, ezetimibe could be added to the statin. Then PCSK9 inhibitors can be added to the statin and we can get the 60% average LDL cholesterol reduction. And later on, if you don't get, then PCSK9 and ezetimibe combinedly. Nowadays the latest bempedoic acid has also been introduced, which also reduces the LDL cholesterol reduction by 85%. Discontinuation of the statin leads to increased CV events. This is also a thing which is to be understood. Do we really need to stop statins at any point of the time? Can we discontinue statin in the elderly patient, those who are having their age more than 65 years? Patient, those who are developing the new onset diabetes, should we stop the statin? Or those who are having the statin intolerance, should we stop the statin? Of course, the statin intolerance, then we will have to stop, but we shall have to find out some other cholesterol lowering agent. What does guidelines suggest? As far as the European Society of Cardiology 2024 guidelines suggest for the elderly patient aged more than 65 years. Treatment with statin is recommended for older people with atherosclerotic cardiovascular disease in the same way as for younger patients. Treatment with statin is recommended for primary prevention according to the level of risk in older people aged less than 75 years. Initiation of the statin treatment for primary prevention in older people aged more than 75 years may be considered if at high risk or above. It is recommended that the statin is started at a low dose if there is significant renal impairment or the potential for the drug interaction, and then titrated upward to achieve the LDL cholesterol treatment goal. What about in diabetes? In diabetes, if the age is less than 40 years, atherosclerotic cardiovascular disease risk of the 10 years is not more than 20%. Then you don't need to give the statin. But if it is, then you need to give the statin with the high intensity lipid lowering agent. If it is more than 40 years, then you need to give the moderate intensity statins if you don't find 10-year atherosclerotic cardiovascular disease risk more than 20%. If you find that your patient is having 10 years atherosclerotic cardiovascular disease risk more than 20%, then in that case you should give the high intensity statin therapy. As far as the patients of the statin intolerance are concerned, American Heart Association in 2024 suggests in patients with statin associated side effects that are not severe, it is recommended to reassess and to re-challenge to achieve a maximal LDL cholesterol lowering by modified dosing regimen, an alternate statin or in combination with non-statin therapy. In patients at increased atherosclerotic cardiovascular disease risk with severe statin-associated muscle symptoms or recurrent statin-associated myalgia, despite appropriate statin re-challenge, it is reasonable to use the RCT-proven non-statin therapy that is likely to provide net clinical benefit. European Society of Cardiology in 2024 suggests in patients with confirmed statin intolerance or in patients in whom a statin is contraindicated, ezetimibe should be considered. So American Heart Association 2024 suggests about the patient of the statin intolerance. Individual patient having the atherosclerotic cardiovascular disease, taking a statin, you can continue with that, but if you are finding that statin intolerance, then of course you need to down titrate the statin doses. Keep it less than 20 milligram of the dose. If it is having strong statin intolerance, then you can remove from the statin, you can look for the alternative agent if the LDL cholesterol is more than 70 milligram per deciliter. In case if it is on partial SI or already on ezetimibe, you can give partial statin intolerance to ezetimibe. If already the patient is taking the ezetimibe, then you can add the PCSK9. Actually, what is the ezetimibe works? Because many people are non-physician, that's why I tell ezetimibe is the enhancer of the statin effectivity. What does the statin do? So 10 milligrams statin works like a 20 milligram or 30 milligram statin if you add the ezetimibe in that. So this was the you can say catalyst of the statin. In some special cases, statin should be either stopped or not to be initiated. So many of obstetricians may be here, they know that pregnancy is not a time when statin should be continued. You should stop the statin if the lady is taking the statin before entering into the pregnancy. In premenopausal patient with or without diabetes who are considering pregnancy or not using adequate contraception, and chances are there they may get pregnant anytime, they should not be advised to take the statin, because statin should not be there once the lady is conceiving and child formation is taking place. Organogenesis is getting in. Heart failure patient in the absence of other indications for their use. Aortic valvular stenosis without CAD to slow progression of the aortic valve stenosis in the absence of other indications for their use. Dialysis dependent CKD patient who are free from the atherosclerotic cardiovascular disease, you don't need to give it. In mild to moderate hepatic failure cases with SGPT level more than 3 times of the upper normal limit, then CK level, creatinine kinase level 4 times or more than that of the upper level of the normal with persistent symptom. CK level more than 10 times of the upper level of the normal. So take home message is, for lipid lowering, rosuvastatin is more effective than atorvastatin. For primary CV prevention, both atorvastatin and rosuvastatin have strong data, but in diabetes patient, atorvastatin has stronger data. For CKD patient, atorvastatin preserves eGFR, while rosuvastatin reduces the eGFR. Atorvastatin is preferred option for the patient those who are having the kidney compromised function. In PCI, both atorvastatin and rosuvastatin has good data. Atorvastatin has a strong CV outcome data in secondary prevention. Rosuvastatin has no CV outcome data in post-MI patient. So, of course, rosuvastatin is a step-up therapy of the atorvastatin. Many times it is considered it is more costlier also, but the tolerance is also the better of the atorvastatin, and it has been found to be the better outcome, better results.